Hello.
Hello.
Hi, Debbie. Hi.
Hi, hello. Yes, we're all here.
Okay. Good morning, everyone.
Good morning.
Yeah, I think just 1 minute. We can. You may start.
Okay. If we are ready, we can actually start. Let me just introduce first. Are we online?
Yes.
Yeah, we're all online. Yeah,
Okay, good.
Yeah.
If it's okay, we can just sort of start. So I would like to first of all welcome everybody to this webinar of sorts on new dimensions and breakthrough in hypertension treatment, part 2. And I have the pleasure, I'm David Quek from Kuala Lumpur, doing this webinar, and I would like to thank the TSOC for actually helping the APSC for arranging this sort of a sequence of symposia. So today I have Professor Cheng from who is going to give us the first talk. So I'm just going to introduce him first. Hello, Prof. Cheng. Professor Cheng Hao Min is actually Center for Evidence-Based Medicine from the Taipei Veterans General Hospital, and also from the Department of Public Health Faculty of Medicine at the National Yang Ming University. And he's going to talk to us about home blood pressure and office blood pressure, ambulatory BP, central BP monitoring. I think these are actually important concepts that we sometimes forget. But actually, it's good to cut back to this because then we can actually understand how the treatment complexity of hypertension is. So are they all equal in guiding hypertension treatment? So over to you, Prof. Cheng.
Hello.
Thank you.
Yep. Hi, everyone. Can you read my slides?
Yep, it's very good, very clear.
Okay, thank you. Yeah, it's my great pleasure to present in the APSC about the different BP measurement modality in guiding hypertension management. Okay. And I will start from introducing, this is my presentation outline. I will start from introducing the utility of ABP. And some of you probably are not familiar with the concept of central BP and ULBP. So I will briefly introduce central BP and ULBP concept. And I will present very shortly the evidence of home BP management in guiding hypertension management. And I will also present the midterm report of our recently conducted ongoing randomized control trial. And we are all familiar with the different BP measurements at different BP values. And we usually use the obvious BP to guide our treatment. And although long been criticized, the obvious BP is the measure with the large outcome trials. And home BP has been emerging as a very useful tools in guiding hypertension treatment. And it's widely recommended by many international guidelines. And ambulatory blood pressure is regarded as the gold standard of the BP measurement, but it can cause some discomfort to patients and also cause annoyance during sleep. Okay, so what's the uniqueness of ABP? And I think ABP monitoring can provide some very important clinical utility that traditional office BP cannot offer. It can measure the BP in out-of-office BP condition, and also it can describe the BP with diurnal change. And it can help us calculate the BP variability in 24 or even 48 hours. And it can also help us evaluate the BP treatment efficacy in 24 hours, not only in the office. And the prognostic significance of ABPN has been widely recognized, and as shown in this paper published in JAMA. The ABP can help us classify the blood pressure, the patients into the dipping or non-dipping status. And as you can see, the patients with reverse dipping or non-dipping has a worse prognosis than the normal or extreme dipping. But such prognostic significance is gradually disappear if we adjust it for the 24-hour SBP or nighttime SBP. And this suggests that the very important prognostic value of nighttime SBP. And what about, what is central blood pressure? Central BP is the blood pressure measured at the central aorta or the carotid artery. And it's very different from the peripheral BP in terms of its peak and the amplitude. But mean BP and DBP are similar between these two waveforms. And as you can see, the very famous case study, which is published in Circulation 2006. And this paper ignited the huge interest in the central BP concept because it demonstrated that the new drugs A plus C versus old drugs B plus D and can have very different outcomes, but their brachial BP are quite similar. But if you measure the central BP, there were large differences in the central blood pressure. And we also previously demonstrated that the central BP, either SBP or pulse pressure, is better than the brachial BP in predicting the cardiovascular mortality, even we adjust many confounding factors. And currently, blood pressure can be estimated non-invasively, and especially through the applanation tonometer, and using the generalized transfer function, or the pulse wave analysis, or the MPMA, the mathematical low pass filter, we can convert the peripheral waveform into the central waveform. And so we can estimate the central BP non-invasively. And our innovation, sorry. Okay. And our innovation is that we can use the oscillometric signal as the surrogate. As you can see, with a fixed cut pressure, we can observe the oscillometric signal very similar to the peripheral waveforms. So using the surrogate waveforms, we can also utilize the prediction equations or GTF or MPMA to get the central BP estimate. So it's very convenient that we can use the oscillometric BP monitor to get the central BP. And we published this concept in hypertension research. This is the first oscillometric CB monitor across the globe. And we further transfer this technology into the manufacturer MicroLife. And further, we present that using the low pass filter, the endpoint moving average with the denominator 6, we can also estimate the central BP. And now there are virtual devices for central BP measurements. It's crowded with many BP device companies. They can all build up the central BP monitors to estimate the non-invasive central BP. And with that, we need a cutoff to define the hypertension. So we use the validation design to determine the optimal cutoff for a diagnostic hypertension. And this paper published in JACC, and we propose that 130/90 probably is the good cutoff for central BP to define hypertension. And later, James Sharman, one of our good friends, and in Australia, who is very famous, he conducted a randomized control trial which compared the usual care versus the central BP guided strategy. And he demonstrated that the central BP strategy can achieve a BP control with the less use of medication. And later we proposed in our Taiwan hypertension guideline that central BP can be used with a cutoff 130/90 to diagnose hypertension if a patient is clinical suspected but cannot be established. And if someone is interested in the central BP concept, we can he can take a look at this recently published state review paper in Journal of Clinical Hypertension bio group and do the collaboration with and let's take a look about the home guided therapy. And early in back to 2004, the B&J meta-analysis demonstrated clearly that the home BP monitoring guided therapy compared to the conventional control can result in the lower SBP by 4.3 and the lower DBP by 2 millimeter mercury. And later in 2017, published in PLOS Medicine, this meta-analysis further stratified the home BP monitoring strategy into different levels. For example, only the SMBP or the SMBP with automatic feedback, or SMBP with active control, or the SBP with tailored therapy. And you can see that the SMBP with additional support can further lower the SBP by around 3.3 millimeter mercury, and lower risk of and in our just issued the National Cardiovascular Disease Guideline by our Health Promotion Administration, we suggest that patients with hypertension can use the home BP with additional support, for example, the self-titration strategy to better control our blood pressure. And we are now to build up the infrastructures of home BP, the team-based hypertension management in Taiwan. In the future, with the help of ICT and additional support from the other health professionals, we can probably better control the blood pressure. And later, we take a quick look about the ULBP. And this concept, the ULBP concept, is very popular recently because of publication of SPRINT trial. And SPRINT trial you are all very familiar with, that intensive treatment can lower the blood pressure, the risk of primary endpoint by 25%, and the all-cause mortality by 27%. And the European researchers suggest that hello, everyone. Can you hear me?
Yes, I can hear you now.
Okay. So the European researchers suggest that the SPRINT trial is the only trial that adopted the ULBP concept. And the ULBP is the blood pressure measured in the quiet room with an average of 3 measurements by automatic device, and the blood pressure should be measured with a rest of about 5 minutes. And this concept is very first proposed by a Canadian researcher, Meyer, and he demonstrated in his figure that the LBP can help eliminate the white coat effect. If we measure the blood pressure in our clinic, the physicians measure, it will interfere by the white coat effect. And after a rest of 5 minutes, you can see that the blood pressure lower down. And at the take of average, we can get the ULBP, which is lower than the conventional obese BP by 20 millimeter mercury. And but whether or not unattended is an issue, and this debate is studied in a paper published in Hypertension. As you can see in this paper, the attended versus unattended, the blood pressure, there's a very minimal difference, about 1.5 millimeter mercury. And the correlation coefficient is very high. So the key issue is the full rest for a minimum of 3 to 5 minutes. Unattended probably is not a key issue. And later, a meta-analysis published in JAMA Internal Medicine and demonstrated that in very many previous studies, suggests that the LBP is lower than the conventional office BP by 50 millimeter mercury. So the hypertension is not defined by 140/90 in the real world. And it further suggests that the average of awake ambulatory blood pressure is very similar to LBP. So LBP is probably the surrogate of awake ABP. I think the conclusion should be cautioned, because if you take a look at this blend and Elman plot, although the right panel, the average between the LBP and LBP is quite similar, the same, but there's a systemic bias as shown in this blend and Elman plot. So the average is similar, but there's a systemic bias. So you cannot reckon these two methods as the same. And we further describe the component of LBP in our national guideline, in our hypertension guidelines. There are four essential elements, EMA. The LBP should be measured by the electronic automatic device with multiple readings, and after take an average, you can get an LBP, especially in the unattended and disturbed space. In our 2017 Taiwan hypertension guideline, we adopted a two-pathway approach. If we use the traditional office BP, we should adhere to the traditional target. But if you use the ULBP, we should adopt evidence from the spring trials. And the last part, I will present very shortly the midterm results of our randomized control trial. And this paper, this protocol has been published in the trials. So you can look at the details about the trial. And the research question is that we have many good strategies in guiding hypertension treatments, but which is the better one? So we hypothesize that the home BP may be non-inferior to LBP and central BP in reducing the ambulatory blood pressure. And here is the measurement method. We take the ALBP and CBP at the same time in the clinic and the daily home BP. And we measure the ambulatory BP at 3 months and the end of 12 months follow-up. And the inclusion criteria is that the patient should have the blood pressure with 2 types of medications and between 130 and 180, or the fresh case. And we will use the blinding technique that all BP measured simultaneously and the blood pressure will be recorded in the standard format without the knowledge. The physician and patient have no knowledge about the allocated intervention. And also the outcome states are not, have no knowledge about the allocated intervention. And we use the cutoff of 2017 ACTH guideline that 130 and 80 for office BP and home BP. And for CBP, we use our previous criteria and also the distributions published in our previous, this is the National Health Survey, so that we use the same 130 and 80. So as you can see that we use the one common threshold for the drug adjustment suggestions, 130 and 80. And the adjustment strategy is based on the our Taiwan hypertension guideline. And here the study flow. As you can see, we randomly allocated our patients into 3 arms, and we follow up regularly, and every regular interval. And at 3 months, we will measure the ambulatory blood pressure. This is the primary endpoint. And at the end of 1 year, we will measure again the ambulatory blood pressure. And here's a midterm report. We in 3 groups, all baseline characteristics are quite similar. And this is the preliminary results. As you can see, at 3 months, the home BP is non-inferior to ULBP or CBP in reducing the ambulatory SBP and DBP. OP value for non-inferiority is significant. And at 12 months, as you can see, the home BP is even better. That it is also non-inferior to UABP and CBP, but actually for SBP is superior. For SBP and DP is superior. So ladies and gentlemen, in conclusion, ambulatory blood pressure monitoring has superior prognostic significance, and it is widely regarded as a gold standard of the blood pressure measurement. And central BP is different from conventional brachial BP and can be measured non-invasively. And unattended automatic office BP can successfully eliminate white coat effect and represents a more accurate BP than office BP. And the home BP management in conjunction with self-titration strategy or additional support can help a better BP control. And our preliminary results of gene studies suggest that home BP is non-inferior to central BP and ULBP in guiding the hypertension management. Thanks for your attention. Any questions and comments from the audience?
Hi, Prof. Ching. Chitang here from Heart Center.
Okay, sorry. Okay, sorry. Yes. And any comments? I was just thinking that maybe we should do the questions and comments after the second talk. Okay, we will have some time for that. Okay. So Prof. Cheng, thank you very much for your talk. We'll go on to the second talk by Prof. Sazli, I believe. Can we have his introduction slides on the first page? Yeah. Okay, now Prof. Sazli Kasim is a friend of ours from Malaysia. He's actually the Professor of Medicine, Director of Hospital, UITM, Mara Institute of Technology in Malaysia. And he's going to talk to us about the treatment of hypertension in extreme weather. In Malaysia, believe us, it is actually hot and rainy most of the time. Hot is the word. Okay, without much ado, can we ask Prof. Sazli to go on with his talk first?
Thank you, David. Thank you very much, APSC, for the invite. As David had rightly said, Malaysia is pretty much warm and humid. Hence, we are not really exposed to extreme changes in temperature throughout the year. Our temperature ranges from 23 at night to about 34 degrees in the afternoon. This talk pretty much is probably more relevant to those from northern or southern countries below the Tropic of Cancer, where you experience 4 seasons in the year. Having said that, I did spend 2 decades of my life studying and training in Ireland, and that's quite far north. For those of you who have been there, the summer is always cold and wet with 1 sunny day, and that's pretty much it. That's all you get for the rest of the year. On that note, I shall be taking you through my talk on the treatment strategies for hypertension in extreme weather. And I shall be discussing on 3 points: effects of extreme weather on cardiovascular disease, and of extreme weather on blood pressure, and how we should approach adjusting treatment for patients with hypertension in extreme weather, and what are the implications. So as we all know, global warming is on the rise. Temperature has risen by almost 1 degree over the past 60 to 80 years. And this has resulted in erratic weather across many countries in the world. We're experiencing drought in places where we have tropical forests. We're experiencing the melting of the ice cap, rising sea levels, etc., etc. And certainly some areas, such as us in Malaysia, we've been experiencing heavy rain for a good number of months now, lowering the early morning temperatures very nicely. But sometimes we have extremes where you have dry weather in Indonesia, for example, contributing to forest fires and haze, which really does increase the incidence of respiratory tract infection, for example. Weather has multitudes of effects to the onset of many types of disease. We'll be focusing on cardiovascular disease here, but quite interesting that this paper from Spain showed that even warm weather could be the reason why a lot more people are suffering from gastroenteritis, possibly due to increased number of bacteria multiplying in dirty water, or the number of people walking and tourists presence in touristic areas contributing to the number of cases. But it's just interesting that the weather has so much effect to our daily lifestyle. The effects of weather and cardiovascular disease is really not something new. It was first reported almost 80 years ago by this group, Master and Jaffe and Jama, where they were looking at risk factors contributing to coronary artery disease and coronary thrombosis. And what they found was that in the autumn and winter period, there is slightly increased incidence of heart attacks as opposed to during the spring and summer. Although the percentage difference is not that great with no significant p-value, this trend was observed many years ago. And we have been getting many reports regarding the effect of weather to the onset of stroke, to the onset of heart attack, to exacerbation of asthma and COPD. And it is very important to understand the concept that it has two effects to the body. Generally, you can be in a climate, in a stable cold climate, and be safe. Be in a scenario where you are exposed to extreme changes in outdoor temperature, which tends to contribute to a lot of the incident of heart attack and stroke. Here, for example, this study by Hong in Korea showed that ischemic stroke seems to increase the longer one is exposed to a lower temperature. Where you, after correcting for humidity and air pressure, the odds ratio of developing a stroke in winter is higher than it is in the summer, almost twofold higher than it is in the summer. A similar paper in Japan looking at the onset of a stroke found that the temperature seems to play a role for women, but not men, where the odds ratio of developing a stroke when the winter is extremely cold for more than 10 days is roughly between 5 to 6-fold higher compared to the summertime. In Ireland, you could really get 4 seasons in one day. In Malaysia, it's either hot and sunny or hot and rainy, and the odd haze that pops up every so often. But in the summertime, where the temperature is about 20 degrees, you could still be exposed to sudden onset of hail and sleet, making life quite miserable for the rest of the afternoon. Here, there's this paper in Germany from Europe that shows that rapid changes in temperature, in ambient temperature, is associated with increased presentation to the emergency room department. So if you were to have changes in temperature of say 5 degrees dropping from say 20 to 15 or 15 to 10 degrees, the odd ratio is almost 30% increase for someone or patients to present themselves to the emergency room department with a chief cardiovascular complaint, i.e. chest pain or breathlessness. There is a lag to when somebody is exposed to a change in weather. For example, immediately after you step out of your office or your hospital or your room or your home, where the ambient temperature in your room would be around 20 to 24 degrees, and the outside temperature is lower, say 10 to 12 degrees, immediately you will start to experience vasoconstriction, increase in heart rate, and subsequently your blood pressure will start rising. Most people will normalize in a few minutes. Some who are exposed, who have hypertension, would see an increase in their blood pressure. Some would suffer events immediately. However, in this German study, you can see that a drop of temperature by 5 degrees is associated with cardiovascular complaint to the emergency room department. And they also took into account the lag, how many days a person is exposed to change in temperature. So it does not necessarily happen straight away. It can manifest itself up to 3 weeks after being exposed to sudden change in temperature. If we were to look closer to home, here's a study from Taiwan, sampling 4 cities, 2 in the north and also 2 in the south, looking at the presentation of patients to the emergency room department, either with a cardiac complaint or a respiratory complaint. And what they found was that when the weather is in the extreme, ambient temperature suddenly dropping, or the very, very cold, very hot, up to the 95th percentile of normal temperature, cardiovascular complaint seems to rise in the middle box. And they found that the annual first extreme temperature event and long duration of extreme cold has more association with emergency room visit than the ambient temperature. Even in a country like Taiwan, there's differences between north and south of the city, where the south is slightly warmer than the north. And they found that there's higher percentage of people presenting with cardiovascular or respiratory tract complaints when the weather changes suddenly. When we look at a larger data set, especially that coming from China, city of Guangzhou, Wuhan, and Shanghai are located slightly south compared to Beijing and Tianjin. And you could see that the effect of extremely cold temperature increases the risk of ischemic heart disease by looking at the odds ratio of 1.89. Up to 3 weeks after exposure to extreme cold temperature, where the weather changes by 5 degrees Celsius, as opposed to the very early onset of being exposed to extreme cold temperature between 1 or 2 days, the odds ratio is still fairly low. Why are the odds ratio higher in southern cities compared to northern cities? Now, this is actually quite interesting because it has relationship to how population health is being managed. One of the theory is that in cities that are used to cold weather, they have more efficient home heating and office heating system, and the ambient temperature is managed better, as opposed to southern cities closer to the sea, where the home heating system may not be as efficient. And when you have sudden exposure to very cold weather, they are not prepared, and therefore changes in their cardiovascular system occurs, blood pressure rises, contributing to higher incidence of complication. But here we can see it also affects a lot of elderly people. There is a U-shaped pattern in terms of cardiovascular complications in relation to weather, where very, very cold weather affects the elderly with the odds ratio rising up to 1.92 on the column on the right, and very hot weather also affects the elderly with an odds ratio of 1.66, suffering from heart disease and cerebral infarction in elderly Chinese. This is probably down to an inefficient thermoregulation system. Maybe their social support is not very strong. They're not warming themselves up properly when they're at home or going out, or maybe they have other social issues such as inadequate home heating system. These are all some of the theories that is postulated from studies like this. Now this slide does not come out very well, and I apologize. Similar data coming from Japan, where they sampled 47 Japanese prefectures over almost 30-year period of time, looking at diseases such as asthma, attacks, kidney disease, dementia, cerebral hemorrhage, cerebral infarction. And what they found was, apart from renal disease and cerebral hemorrhage, all the aforementioned condition is associated to changes in temperature. between indoor and outdoor, and between daily outdoor temperature, the extreme changes where they change more than 5 degrees in one day. And there is also the association of a lag where the incidence of asthma, cardiovascular disease, and stroke seem to present themselves up to a week later, and many actually present themselves up to a week later compared to 1 or 2 days after being exposed to sudden changes in temperature. And similarly, we see the same effect from our North American friends, where mortality is associated with the cold weather. And now I shall go into how the cold weather actually affects blood pressure. And we have seen some data that pretty much describe countries above the Tropic of Cancer tend to have higher prevalence of hypertension compared to countries closer to the equator. Please do note that the prevalence of hypertension in the population for Malaysia is about 43%. However, the factors contributing to that is probably, part of it is due to diet, sedentary lifestyle, high salt intake, and so on. But what we're interested is there any effect of weather itself to the blood pressure in those living in countries in the northern and southern climate? So we do have data from the MONICA study, which was performed between 1979 and 1999 in 16 countries, and looking at countries above and below the Tropic of Cancer and Capricorn. And what they found was that the higher you are in terms of your latitude, you do tend to get smaller variation in your blood pressure between seasons. And this would say or tell us that maybe these countries have adapted to the changes in the weather better as compared to countries who are closer to the equator, where they would experience changes in the weather and they are less prepared in terms of clothing or household heating or healthcare support. They see a bigger variation in blood pressure swing between seasons. Is hypertension more prevalent in winter? This slide seems to suggest that it is. And as the temperature drops, if you were to look at systolic blood pressure column on the left side, the left hand graph on the y-axis is your systolic blood pressure measurement in millimeters mercury. Opposite is the temperature between 0 to 35 degrees. As the temperature drops, systolic blood pressure tends to rise, and they tend to happen during the month of winter between November to March. The same patterns is seen as well with diastolic blood pressure. In Europe, in Italy, from the Pamela study, I think about 2,050 women, they saw a similar pattern. And it doesn't really matter whether you measure these blood pressure in clinic, at home, or you do 24-hour ambulatory blood pressure monitoring. Here in the Pamela study, you can see that the values from 24-hour blood pressure monitoring, home monitoring, as well as clinic blood pressure measurement in the column on your right for systolic blood pressure seems to mirror each other quite nicely. Highest in the winter months, and seems to be lower during the summer months. There is a pattern for blood pressure variation with regards to weather, and this is an Australian group studying a population near Shanghai, about 50,000 of them who were followed up for about 10 years, and they found that there is a V-shaped pattern in terms of your systolic blood pressure in response to changes in temperature. The lower the temperature, the higher systolic blood pressure, and then it seems to reach less of a variation with a temperature between 20 and 27 degrees. However, temperature above or closer to 30 degrees Celsius seems to have greater variation of blood pressure as well. So now we know that blood pressure rises in cold weather and blood pressure rises in warm weather as well. When it's warm, the blood pressure could rise because of annoyance to heat, for example, or other factors that contribute to it as well. So this is a large study, about 500,000 people from various zones in China, where it's divided into temperate zone, temperate monsoon zone, as well as subtropical zone. And what you can see here is a pattern of changes in blood pressure compared to the ambient temperature outside. And it's quite interesting because, as I mentioned earlier on, cities or population who are located in the subtropical region tend to tolerate changes in ambient temperature less compared to those who are from colder climates, where they are better prepared. Blood pressure variation in those populations further up north is less compared to those sitting closely to the ocean. So a greater systolic blood pressure change due to lower temperature was observed in subtropical zones, especially for cold season. And what's interesting was that they've also isolated that female people in the rural area, as well as elderly population, were more susceptible. So these are people really be focusing when we experience extreme change in the weather. We also have data coming up from India in the area of Jaipur, where they sample almost 1,000 patients, and they monitor them for several years and monitoring their blood pressure during different types of season. And to look at the bar graph on the top right-hand corner, you can see that in the summer, systolic blood pressure average is about 122, and it rises to 131 in the winter. So these hypertensive patients are at risk. This paper from Canada in about 50 with a mean age of 64. These are the patients who we look after with hypertension, and they have hypertension. And they found that when these elderly hypertensive are exposed to extreme cold weather, they have a 37% increase in the risk of presenting to the hospital with hypertensive crisis or hypertension-related complication that needs admission. Similar pattern is seen for diabetes, although the relationship is not very strong. There was no association with arrhythmia. So here they found that 9.3% was associated with exposure to cold temperatures in the moderate range compared to 0.7% extreme temperature changes. What about the hot weather? As I showed you, the Pamela study showed that in the during the summer, blood pressure seems to drop gradually. This is interesting because one might be tempted to reduce the number of blood pressure medications, especially in the elderly, to try and compensate and avoid complications such as postural hypotension and dizziness. However, they also saw that strokes don't actually decline during the summer, especially among the elderly. And it gives rise to a question of why. And from this large study from Modesty, they found that in the rightmost column in C, where the C's are elderly patient, they found that elderly patients tend to have higher nocturnal blood pressure reading during nighttime in the hot weather in the summer. And this could be a problem as well because they do have a higher degree of blood pressure surge early in the morning. And that could be the reason why, despite a lower summertime blood pressure reading, the elderly patients are still getting their stroke because they are getting their early morning surge and their nighttime systolic blood pressure is also higher, i.e. they're not adequately controlled. So this pretty much should be flagged because we do need to pay attention to them closely in terms of medication, timing of medication, how they take the medication, and whether or not they are getting side effects from the medication, rather than having a blanket of withholding medication or reducing medication during the summertime for our elderly hypertensive patient. The elderly and the very poor are very susceptible to temperature changes. In the heat of the summer, where due to poor accommodation, they might experience a rise in blood pressure as opposed to a drop in blood pressure. And it's probably because their bodies are heating up. Now, some of the mechanism that is associated with the weather, in the cold, it could be due to vasoconstriction, activation of sympathetic nervous system and tachycardia, as well as the retention of sodium and water, as well as of impaired endothelial vasodilatation. In the heat, the reason why the blood pressure drops is because of water loss and also from vasodilatation. Please note that if the nighttime temperature is high, as for example in the summertime, it could also result in higher blood pressure, and one of the postulated mechanisms will probably be due to reduced sleep duration. The weather also plays a role in the winter. The lack of vitamin D due to the short exposure to the sun, reduced daily activity as well as weight gain are all contributors to higher blood pressure. We did not talk so much about altitude. However, people who are not used to high altitude tend to experience hypoxia and activation of their sympathetic nervous system, and a rise in their adrenal activity can contribute to high blood pressure due to a stress response. However, those people who live like in Tibet and the Andean Alps, for example, who are already acclimatized to high altitudes, they seem to respond by having a lower blood pressure compared to those who are not used to high altitudes. I've shown you slides on the effects of latitude to the incidence of hypertension, and some of the possible mechanism would be to genetics, where migration, ancient migration resulting in changes in how the body handles salt and water retention, especially moving from equator to northern climate where both are readily accessible. So how do we adjust our treatment in extreme weather? It's not really that straightforward. If there is a patient that you're considering having uncontrolled high blood pressure due to weather exposure, they should really be advised to dress appropriately, look into the home heating system, look at the support system. The treatment option is not just one size fits all, because we do have to look at the individual, at the community, and at the hospitals. For example, guideline mandated therapy are all in the guidelines. There are no mention about adjusting treatment for hypertension during extreme weather changes. However, I have shown you a slide that the blood pressure tend to drop in the summer. So there are certain population who are at risk, i.e. the elderly and the poor, who we should really be paying extra care and extra attention to in terms of their medication, maybe reduce the dose of diuretics, but monitoring their blood pressure closely, because we do know that these patients are susceptible to early morning blood pressure surge, contributing to target organ damage such as microinfarcts in their brain. Public health interventions such as better heating for homes and making sure that the community have support for these patients who are exposed to extreme weather variation is also.
Prof. Sazli, I'm sorry to interrupt you. Okay. Can we have Prof. Sazli to wind up the conclusion, please, and then we'll go on to some questions and comments for 3 to 4 minutes.
Just as well as I'm finishing that, David. So
yeah, sorry.
In conclusion,
yeah.
Cold temperatures lead to a high blood pressure acutely and between seasons. Extreme temperature shifts is dangerous because it increases blood pressure, a U-shaped pattern in hypertensive subjects. And warm weather tend to result in lower systolic blood pressure. We have to be careful in how we manage them, especially the elderly where they have impaired thermoregulation. Reducing medication might be the default thing that we want to do, but it might result in poor nighttime blood pressure control, contribute to stroke. And as I've mentioned before, intervention requires multiple levels of strategic planning. Thank you, David.
Okay, thank you. Can we now have some questions? I think Prof. Chin from Singapore had some questions earlier. Before that, I'd like to thank both speakers for giving us a very comprehensive review today. This is where I am. Okay, sorry. I'd like to thank the two speakers. And now we have a few quick questions and then we have to move on, okay, in the interest of time. So Prof. Chin, I think you have a question and a comment earlier. Quick one. Yeah.
Thanks, David. I wanted to pick Prof. Ching's brain actually. In terms of home BP monitoring, how do you normally suggest to your patients to do this? When do you do it? How often, etc. Morning, evenings, etc. What is your normal practice?
Okay, and now we have a national home BP consensus statement on this issue. We suggest a 722 principle. 722 means 请凉凉 is in Chinese. Please measure your blood pressure, 请凉凉. So 722. So you should measure the blood pressure seven days, at least 6 days. And every time you should measure twice, and two specific time points, one in the morning after waking up and one at night before you go to sleep. So this is the standard suggestions from our home blood pressure experts. So 722 principle.
But that's mainly for diagnosis, right? How about monitoring of therapy and day-to-day, you know, titration, etc.?
Okay, yeah. So in our also consensus statement, we recommend that we should use the 135 and 85 if our target is 140/90. And if we use the ACCHA guideline, the 113/80, so the same target, 130/80 should be applied. So for our patient, for our practice, if the patient had the average home BP more than 113/80, we will titrate the medication. And in my practice, I will suggest the BP should not be lower than 120. So if the BP is about 100 or 110, I will suggest to decrease the medication. So this is my current practice.
Okay, thank you very much. I think in the interest of time, we need to move on. So I'd like to invite my co-chair, Prof. Chen, Prof. Chen Chun-Huan, to take over for the next session. Prof. Chen?
Yes, good afternoon, everyone. I'm Dr. Chen, a cardiologist from Taipei Veterans General Hospital. Thank you all for finding time and joining today's webinar. There will be 2 talks in the second session of today's webinar. Our first speaker is Professor Masood Sadiq. He is Professor of Pediatric Cardiology and Dean of the Institute of Child Health Children Hospital, Lahore, Pakistan. The title of his talk is Treatment Strategy for Hypertension in Coarctation Aortopathy in Adults. Let's welcome Professor Sadiq. Professor Sadiq.
Thank you very much for the kind introduction. Let me share my slides. I hope you can see my first slide.
Yes.
Okay. Treatment strategy for hypertension in coarctation aortopathy in adults. This was a relatively difficult topic because if you look into the literature, you don't find much about any randomized controlled trial or any other major large study looking at treatment strategy for hypertension in coarctation aortopathy in adults. Outline of my talk would be that I will give you a background and a cardiovascular sequelae of coarctation of aorta, a very brief touching the pathophysiology of hypertension aortopathy in coarctation of aorta, what types of hypertension we see in adults with coarctation, indications and options of intervention, medical therapy with specific factors affecting the decision making, and how do we follow these patients with conclusions. If we look at coarctation of aorta, this is the 6th most common congenital heart defect. And if you look at the percentage of all congenital heart defects, it's about 4 to 8% of all congenital heart defects. 4 out of every 1,000 live births has coarctation. There is a clear male predominance, and they are often associated with other congenital heart defects, the most common of them being bicuspid aortic valve, which is up to 50 to 75% of these patients. Left heart obstructive lesions, ventricular septal defect, and patent ductus arteriosus are the other associations. One important association to mention here is cerebral aneurysm, which occurs in up to 10% of the patients, although it's now very obvious that hypertension and age seem to be important factors in these cerebral aneurysms. And interestingly, if you look into the literature on large studies in adults, up to 10% of the patients with coarctation are being diagnosed after the age of 40 years. So it is not uncommon to miss the diagnosis as a child or a young adult. Now, if we look at the cardiovascular sequelae of untreated or late repair coarctation, of course, the most important one, the one which we are talking about today, is systemic hypertension. Of course, premature coronary artery disease, stroke, aortopathy leading to aneurysms, dissection and rupture, infective end arthritis, heart failure because of LV dysfunction, concomitant cardiac lesions producing hemodynamically significant lesions, and a sudden death are all well-recognized cardiovascular sequelae if we don't treat coarctation or we treat it late. Coarctation aortopathy is a lot of people, or if you look into the literature, this is considered as a general arteriopathy. And you see abnormal histology of arterial wall, both adjacent to and distal to the site of coarctation. And medial wall degeneration has been observed in both pre and post-stenotic specimens. Whether chronic hypertension alone contributes to this aortopathy, I think there is a modest aortic root dilatation associated with chronic hypertension as well. And when more extensive aortic dilatation is seen, one must suspect other causes for aortopathy as well. Now, what is the incidence of this aortopathy in coarctation? The reports are variable, but this large long-term study from Stewart and his colleagues shows that the incidence of dilated aortic root in coarctation is about 16%. It is more so in patients who had surgery later in life. And 5 out of the 6 patients in their series who died from aortic aneurysm had original surgery at a mean age of 19 years. So delayed surgery of coarctation of aorta and associated hypertension are two clear mechanisms or associations with this aortopathy. Whether you repair them early and they would not develop aortic dilatation, I think this needs to be seen. And biopsy studies have clearly shown increased amounts of collagen and a decreased smooth muscle cell content in pre-stenotic region. Now, coming to systemic hypertension and coarctation aortopathy, systemic hypertension is the major long-term problem following repair of coarctation of aorta. And it's surprising to see that 35 to 68% of the patients, even with an anatomically satisfactory repair, would have hypertension. And the incidence increases as your age increases, and up to 90% in patients who are above 70 years of age. If we start exercising these patients, exercise-induced hypertension is seen in up to more than 1/3 of these normotensive patients. And if you look at the factors which are related to this persistent or recurrent hypertension or a disproportionate systolic hypertension, patients whose repair is performed later in life, or the repair is either incomplete or there is residual gradient through the stenosis. And of course, it is significantly lower in patients who are treated in neonatal age or infancy, or those who underwent coarctation resection with end-to-end anastomosis where there was no residual coarctation segment left. So what is the exact pathophysiology of this late onset hypertension after the repair? I think arterial wall compliance is diminished, rigidity is increased, and I think it's this reduced aortic compliance and an abnormal baroreceptor function which might explain this significant hypertension. It's also associated with an abnormal geometry and even a mild residual lesion, which is often seen in the coarctation arch or a disturbed renin-angiotensin-aldosterone system. Of course, they also play a little part in late onset hypertension. If we look at hypertension in coarctation, there are 4 major subgroups, and I think this is very important to understand. Patients who have unoperated or native coarctation, or where repair was done early in childhood, we tend to see what we call persistent hypertension. Recurrent hypertension occurs in patients who had an early surgery as an infant or a neonate, and then they develop recoarctation later in life, and the hypertension reappears. One very important type of hypertension which we see in these patients is what we call dynamic hypertension, which you only pick up on either ambulatory blood pressure monitoring or exercise induced, and this typically follows repair at a later age. And one topic which obviously is beyond the scope of today's talk is paradoxical hypertension, which you see immediately post-intervention or post-surgery. Of course, any of these, and particularly the first two, can be resistant or refractory hypertension and very difficult to treat. I thought this management algorithm by Nakamura and his colleagues, which was published fairly recently, gives a very comprehensive overview or a picture how you should be managing these patients with hypertension, aortopathy, in coarctation of aorta. I think when it comes to indications, we know that peak to peak coarctation gradient, if it is less than 20, then of course you would look for alternative diagnosis, because then this may not be the sole reason for hypertension. But if you have significant collaterals or the gradient is more than 20, then of course an expert adult congenital heart disease consultation is required, who would start the medical therapy and then would decide what type of intervention is required. Remember, the most important treatment of hypertension is to relieve the gradient. Unless we have complete relief of gradient, the management of hypertension in these patients is extremely difficult. So if you have a complex coarctation or a neonate, you will go for surgery, or a young infant under 25. And if it's a coarctation which is not associated with another defect, and the patient is older than 30 kilograms or more, you go for transcatheter repair. When it comes to medical therapy, and we will be talking about that more in a moment, there are three major groups which we use in these adults with beta blockers, ACE inhibitors, and ARBs. And of course, in these patients, you always consider routine provocative testing for management of hypertension. It's a rather busy slide looking at interventions for intervention, but I think we all know that if you have a pressure difference of more than 20 millimeters of mercury between upper and lower limbs, regardless of symptoms, you need to correct that, that coarctation or recoarctation. Of course, upper limb hypertension more than 140/90. Collaterals can obviously confound interpretation of this gradient, but if there is a pathological blood pressure response during exercise or a significant left ventricular hypertrophy, these are all class 1, although level C indications. But if we look at the hypertensive patients with more than 50% aortic narrowing relative to the aortic diameter at the level of diaphragm, they should all be considered for treatment of hypertension and relief of this obstruction. Even minor or milder obstructions would benefit from this treatment. So how do we go once we have found a patient with coarctation aortopathy? So how do we go about? I think an early surgical or transcatheter repair to ensure that there is no sort of residual coarctation, and this will be to reduce the risk of irreversible aortopathy and refractory hypertension. The choice of repair in adults is again dependent upon the individual patient factors and institution-specific factors. And I think we will be talking about that shortly, although very briefly. And medical therapy for hypertension due to coarctation, although parallels essential hypertension in terms of 3 basic first-line agents as beta blockers, angiotensin converting enzyme inhibitors, and angiotensin receptor blockers. But how do we go about them? I think there are certain factors which would help you in making a decision. If you see a native coarctation in adults, it's one of the most difficult condition to manage and to make a decision as well. The coarctation anatomy is often very complex. Not all coarctations are localized. Many have a tortuous aorta, as you can see here. There is an unknown incidence of cystic medial necrosis, especially in adults, and you may have an associated bicuspid aortic valve and aortopathy. And just look at this angiogram showing you a classical coarctation in an adult and the difficulty which you would have in making a decision. surgery in adults has a very limited place. And I think it has an increased mortality because you may have associated degenerative changes in aortic valve. You might have coronary artery disease or end organ damage due to long-standing, excuse me, hypertension. The three types of surgeries which are often done in adults are either resection with end-to-end anastomosis, and this is the preferred method for initial repair. You can use a jump graft bypass, or you can use an interposition graft. As you can see, the possibilities of operations in infancy or childhood are very extensive. But when it comes to adults with coarctation, I think the choice is limited and the indications are also very limited. When it comes to intervention, balloon angioplasty has only a place in discrete, isolated native coarctation. Ballooning has major issues in adults. Not all are suitable. Major incidence of aneurysm formation. You might have a persistent residual or recurrent coarctation, and there is a very genuine risk of aortic rupture or dissection because these patients have wall abnormalities as I have alluded to. So what is the treatment of choice to relieve the obstruction? I think now it is stenting. It is the percutaneous intervention of choice. You can use bare metal or covered stent depending upon what type of coarctation you are seeing, and similarly an open cell or closed cell. The suboptimal anatomy, which you cannot treat with a balloon, like long segment coarctation, vessel tortuosity, or transverse arch hypoplasia, can all be addressed now by using covered stents, and there are now mid-term and early long-term data which is supporting the very good results with very low mortality and morbidity. We have a big choice of covered stents available with us when we go for these procedures, CP stents, Geomad, Gold, Atrium, and Bentley, and so on. When we looked at our own data as which patients would actually need covered stent, you can see severe coarctation with near atresia, complex arch anatomy with tortuous arch, transverse arch coarctation, age above 40 years, associated duct, long segment coarctations, and severe coarctation with dilated ascending aorta, or what we call aortopathy, or of course Turner syndrome, or as a salvage operation if you're using a bare metal stent. One interesting thing which we found in our own data after a 10 years follow-up was that redilation was needed in only 4 of these 56 patients. But majority of them, although you did see an improvement in hypertension in 78.6%, but majority were still using antihypertensive drugs. Just to show you a classical coarctation with a duct, where you can use a covered stent to get relief for both coarctation and PDA at the same time. Complex coarctations like these ones would definitely benefit from using a covered stent, because you can not only avoid covering the left subclavian artery, but can relieve the coarctation completely with a complete removal of the gradient. When it comes to the recoarctation or repaired coarctation of aorta, then the concept is different. Because majority of these patients, you can actually use balloon angioplasty as treatment of choice unless there is an aneurysm formation. Of course, if it's aneurysm, complex or log segment, after initial repair, you would still consider stenting. But otherwise, ballooning works extremely well in these patients if they develop recoarctation. Next few minutes, I would be talking about the medical therapy for hypertension, which obviously parallels treatment for essential hypertension. But the choice of agent has to be influenced by the ascending aortic size, presence of bicuspid aortic valve with aortopathy, with or without aortic stenosis, presence of a significant aortic regurgitation, and presence of LV dysfunction. All these factors would influence which agent you are going to use for these patients. If there is aortic dilatation, beta blockers may be preferred based on the theoretical benefit of their anti-impulse effect in this setting. Calcium channel blockers hardly have a place in coarctation. because they are generally avoided in the setting of aortic dilatation. Of course, this is based on animal and limited human data suggesting that they may increase risk of aortic complications. And if you have severe aortic regurgitation, beta blockers are typically avoided because they prolong diastole and theoretically may increase aortic regurgitation. Of course, in refractory hypertension, you may have to use more than one of these agents in combination. I think based on primarily on studies which were performed in patients with Marfan syndrome or patients with asymptomatic thoracic aortic aneurysms who are being conservatively managed, I think blood pressure control is best using beta blocker therapy. And I think we know from Marfan syndrome and other aortopathy studies that there is a role of beta blockers in preventing the progression of these aneurysms or dilatations as well. We aim for a systolic pressure between 105 to 120 if it is tolerated. And of course, ACE inhibitors and ARBs are an acceptable alternative among those who do not tolerate beta blocker therapy. And patients with bicuspid aortic valve and a dilated ascending aorta without significant AR, again, beta blockers and ARBs have a conceptual advantage. As I said earlier, there are no randomized controlled trials, no large studies on this particular topic. So there's no evidence supporting a specific agent within the class as which beta blocker, ACE inhibitor, or ARB, and that's very much an individual and institutional decision. One important factor is LV dysfunction. It develops in many patients with coarctation, particularly, of course, there are multiple mechanisms like residual afterload, coronary artery disease, hemodynamic effects of chronic valvular dysfunction, but this abnormal ventricular substrate increases the risk of arrhythmias and sudden death. And majority of patients who die suddenly tend to have significant LV hypertrophy and some level of LV dysfunction. Again, calcium channel antagonists like verapamil and diltiazem are contraindicated if you have a severe LV dysfunction or LV ejection fraction less than 40%. A lot of people would ask you whether they can exercise or go for recreational sports with coarctation of aorta. I think standard lifestyle modifications, as you would do in hypertension for adults in any unrepaired or repaired disease, is recommended. Weight control, aerobic exercises, low fat and low salt diet, smoking, but high intensity static powerlifting or weightlifting, sudden stop start, or isometric exercises and sports should be avoided. And I think this is to reduce the risk of strain on the aorta that can lead to aneurysm formation or dissection. High intensity recreational sports, I think the same would apply as for competitive sports, where you need to have a careful case-by-case evaluation involving exercise stress testing and doing an echo for appropriate risk stratification. They have a risk of sudden death. They have a risk of aortic rupture or dissection. So it's extremely important to evaluate these patients on individual basis. Of course, you can let them participate without limitation if it's a mild coarctation, normal exercise stress test, or small pressure gradient. But I think athletes with systemic or dynamic hypertension should only engage in low intensity competitive sports unless you have done a repair on them. Before I finish, I thought I will just very quickly give a clue about pregnancy in patients with coarctation and hypertension. Of course, a greater risk of developing hypertension during pregnancy and complications related to increased cardiac output. If you have an aortopathy, then you have a risk of aortic dissection or rupture of a cerebral aneurysm. So these patients ideally, but that doesn't happen often, should be evaluated before pregnancy and of course undergo arch imaging. And possible recoarctation should be managed before conception to avoid any uncontrolled upper body hypertension. But I think if it does happen and you have significant coarctation and hypertension, the blood pressure aim should be 120 to 140 and diastolic 80 to 90. If there is no obstetric indication, they should be, those who are normotensive can carry the pregnancy without any intervention, and they can go afterward for intervention, which is typically 3 months post-delivery. But for poorly controlled hypertension during pregnancy, the decision should be individualized. And every effort should be made to manage these patients medically. But if you have to go for a percutaneous intervention using a covered stent, it's possible. The best time is obviously the second trimester during pregnancy, and this should be only done for severe refractory hypertension or maternal fetal compromise. Some papers suggest preventive surgery in patients with aortopathy. And I think there are only few studies which have investigated the impact of coarctation in bicuspid aortic valve patients on incidence of aortopathy. The current ESC guidelines advise to consider preventive surgery at a lower aortic diameter if you have a bicuspid aortic valve and coarctation. So the current guidelines state that ascending aortic surgery should be advised at a lower ascending aortic root diameter of 50 millimeters instead of 55 if you have both bicuspid aortic valve and coarctation. Ambulatory blood pressure monitoring is extremely useful in identifying and managing patients with ambulatory hypertension. 1/3 of patients who are otherwise normotensive would be found to have ambulatory or exercise-induced hypertension. And I think despite surgical repair, this can persist and may not be identified during resting measurements. I think you should, up to 80% with prior intervention would manifest an abnormal elevated upper extremity exercise blood pressure response. And you must exclude restenosis. The treatment starts with correcting the coarctation or residual coarctation. How do we monitor them? I think all patients, whether repaired or not repaired, need lifelong adult congenital heart disease follow-up. Clinical evaluation, measurement of blood pressure at all visits, ambulatory blood pressure monitoring or exercise testing. Of course, this will help in assessing blood pressure control, particularly if it is labile, and should be performed those particularly who are wishing to participate in sports. Imaging, CT angio, MRA, and this is periodic imaging. We normally do it depending upon the underlying etiology, but must be done at least every 5 years. Echocardiography, preferably on every visit, and monitoring for intracranial aneurysms. This is again a periodical cranial imaging surveillance with either MRA or CTA. I would like to conclude by saying that treatment of hypertension and coarctation is ideally an early surgical or transcatheter repair to reduce the risk of aortopathy and refractory hypertension. The choice of intervention, of course, depends upon individual patient characteristics and institutional and operator experience, but transcatheter stent implantation at the moment is the most preferred intervention in adults. The medical treatment of hypertension rests primarily on 3 groups: beta blockers, ACE inhibitors, and ARBs, with no evidence to support a specific agent within any of these 3 subgroups. And specific situations like associated aortic valve disease, aortopathy, LV dysfunction, they demand special considerations. And remember, pregnancy is an added risk in the presence of coarctation or residual coarctation and aortopathy, and shall be managed by a multidisciplinary team, including a congenital heart disease expert. Thank you very much. And I thank the Asia Pacific Society of Cardiology for giving me this opportunity to share this experience. Thank you.
Thank you, Professor Sadiq, for your very interesting talk. I will take questions and comments during the Q&A session after the second talk. Now I would like to introduce our second speaker, Professor Ching Chi Tan. He is Associate Professor from National Heart Center, Singapore. The title of his talk is Interventional Strategy for Treatment for Drug-Refractory Hypertension. Welcome, Professor Tan.
Thank you very much, Prof. Chen, for that very kind introduction. Can you see my title slide, and can you hear me okay? Yeah, all right. So in the next 15 to 20 minutes, I've been asked to give a little kind of taster with regards to the interventional strategies that are now available for managing hypertension. So these are my disclosures. And I'd like to also highlight, obviously, that a lot of the things that we're going to be talking about today are going to be considered not widely available, and many of them are evolving. So this is guidelines from the ESC. So this is the latest ESC hypertension guidelines, and you can see very, it's very clear, the statement that the use of device-based therapies is currently not recommended for the routine treatment of hypertension, unless in the context of clinical studies and randomized controlled trials, and until we get more evidence with regards to safety and efficacy. So really, a lot of the things that I'll be talking about today is not meant for routine clinical use. So let's talk a little bit about the context of high blood pressure. So I think we don't really need to talk too much about the past. In the past, we didn't have much treatment for high blood pressure, and we knew it was a terrible disease responsible for a lot of morbidity from blood pressure itself, but also from other associated clinical issues. So what is the current paradigm now? So the current paradigm is that blood pressure is actually much better controlled. I think we've heard from the previous speakers, we now have much better strategies in terms of managing blood pressure. We understand it much better now. We know how to diagnose it and monitor it, etc. But I think we also need to realize that there are a certain proportion of people who are not well controlled in terms of their blood pressure. And also for those who are so-called well controlled in terms of blood pressure, there are limitations to the current treatment options. So medications are long-term, medications have side effects, compliance to medications is an issue, and all these of course tie in with the overall patient outcomes. So what is the future? So I put it to you that the future of course is a world where blood pressure is no longer an issue, where hopefully people don't have to be taking so many medicines all the time, and outcomes of course hopefully will also be much better. So are we anytime approaching the future? I think that's what my talk today is hopefully going to set the scene. I was in the brief I was given for this presentation, I was asked to talk a little bit about renal vascular disease, and I think that makes sense because this was one of the first few interventions that we had for treating someone with high blood pressure. I think the previous speaker spoke very nicely about coarctation. So this is another form of vascular disease, and it's renal artery stenosis, and we all know the theoretical, the theory behind renal artery stenosis leading to high blood pressure. And in theory, it's very, very attractive to go in there, put in a stent, relieve that renal artery stenosis, and hopefully relieve the blood pressure as well as the other attendant problems attributed to renal artery stenosis. And the procedure itself, as we all know, is technically not that difficult. But what really is the clinical evidence for this? And I think we have been developing more and more understanding of this. I think when it all started about 20 over years ago, the studies were small, they were not very well randomized, follow-up was pretty short. But I think in the last 5 to 10 years, we have had much more evidence come through, and I think our understanding now is much better. So these are the initial small studies, but I think let's talk about the more so-called current studies in terms of outcomes, the much longer follow-up. So Astral and Coral followed patients up for 3+ years, and essentially we could not demonstrate any significant outcomes, any significant benefit in terms of outcomes with regards to kidney outcomes, mortality, or even general cardiovascular outcomes. So just to elaborate a little bit further, this is the Coral study. The Coral study to date is the largest study of renal artery stenting. It randomized more than 900 people to stenting plus medical therapy versus medical therapy alone. And we can see that this is the percentage stenosis as assessed by collab as well as by investigator. The previous studies were always criticized because there was a wide variation of the degrees of stenosis, and some people said that they were not true renal artery stenosis. I think we can see that the data in Coral shows that these were patients with fairly significant renal artery stenosis, and we know the results. So when they were followed up to, I think a median follow-up of 43 months, you can see no real difference between the intervention as well as the medical therapy group. So that has led to the guidelines essentially being very, very unequivocal in their recommendations. Both the Americans as well as the Europeans really see no place for routine renal artery stenosis, renal artery stenting in patients with atherosclerotic renal artery stenosis. Perhaps in certain situations, such as young patients with FMD or people who present with intractable heart failure, there is some discussion about renal artery stenosis, but I think this is very much an individualized discussion. So what else is there? And now we're going to move a little bit away from vascular diseases and talk a little bit more about the autonomic systems. So talk a little bit about renal denervation, which I think a lot of us are familiar with, and perhaps a little bit about baroreceptor modification, as well as carotid body modification, and then present a little bit on AV coupling technology. So this is the renal denervation roller coaster. I'm sure all of you are very familiar with this. Our colleagues in Taiwan actually are leading the Asian wave in renal denervation, actually. So the whole up and down as portrayed in this picture really tells the story of renal denervation. So this is data that came out actually more than 10 years ago now. So this is Simplicity Hypertension 1 and Hypertension 2. In this two initial studies, patients with refractory hypertension, so really very high blood pressure in the office despite many medications on board, went for this treatment called renal denervation, and they had phenomenal results. So you can see that blood pressure by 6 months after the procedure, on average, had dropped 26 millimeters mercury in the office. And this was replicated in a larger study called Hypertension 2. But as you also know, when they went on to do the pivotal study in America for essentially FDA approval, Simplicity Hypertension 3, yes, patients who went for renal denervation did have a significant drop in their blood pressure at 6 months, but so did the patients who were in the control group. And as you know, Hypertension 3 was a very unique study because the control group featured a sham arm. So this is one of the first studies, if not the first study, with a large patient population that employed both an active intervention as well as what you could call an active control, an active sham arm. So patients had basically the same procedure, everything except the actual intervention. You can see that there was no statistically different delta between the two study groups. And because of that, this trial was considered to be non-positive, and the whole technology really suffered a major setback. Up to this point, there were at least 5, 6, 7 companies investing a lot of money in their own renal denervation technologies. But once this came, once this was published, everything basically came to a halt. So, you know, that could have been the end of it, but to the credit of the company, they actually tried to understand a little bit more about what happened in Simplicity Hypertension 3, and perhaps use that to design a better study to try and demonstrate the true efficacy of this technology. So we can discuss this later in the Q&A, but essentially, Hypertension 3, perhaps there were some design as well as execution issues. There were variabilities with regards to patient compliance, patient drug changes, and also perhaps in the way the procedure was done. So now the company, Medtronic, have a new catheter and a new way of performing renal denervation. So now they have a spiral catheter, which eliminates really a lot of the procedural variation in terms of performing renal denervation. You can see on my little video on the right side here, hopefully, this is a wire-based technique. This is a catheter that is in the renal artery. We pass a guide wire into the renal artery itself, and then we push an over-the-wire catheter in, and then withdraw the guide wire, and then you can see that the catheter assumes a spiral shape, which is shown down here. And the idea is to ablate as much of the renal artery as possible. Previously, we ablated mainly the main artery, but now we go into sizable side branches as well, because we have seen from other data that the more ablations that we do, this seems to deliver a better result with regards to blood pressure lowering. And this is a clinical case that we have done here at the Heart Center in Singapore. We do this procedure not frequently, but we've done enough to show that really the results are pretty reproducible. So you can see from the different angles that this catheter truly does take a spiral shape. So you can see on this one, there's a circular shape. So all that's nice, but really we need to have some outcome data. And so this has been trickling in over the last few years. So this is the pilot studies in 2017 and 2018. Very broadly similar designs. One was the hypertension off study, and this one is the on study. And the off study is particularly important because this examines patients who are not taking any medication. So this really removes that variable of medication compliance, titration of medicines, etc. And you can see at 3 months, patients who had the intervention had a significantly lower blood pressure as compared to patients who had the sham procedure. And this is ambulatory blood pressure. So we've talked about in the I think the first presentation how the different blood pressure measuring modalities are important. And so this is ambulatory blood pressure. Very, very difficult to fool this one. And similarly, a year later, we had the results of the spiral hypertension on med study. In this, the patients were taking a very carefully titrated medication regime. And they also showed once again that at 6 months, patients who had the active procedure had a statistically significant lower blood pressure as compared to those in the sham arm. So this is the renal denervation technology as delivered by the spiral catheter. But there are actually other technologies that are also targeting the renal sympathetic system. And this is data from Radiant's Hypertension Solo. So this is a different type of technology, but it serves to try and do the same thing, which is to modulate the sympathetic nervous system, that the sympathetic nerves that run along the renal artery. Patients in this trial were hypertensive, and medications were stopped, and then they had the intervention performed, and they were the outcome was measured at 2 months. So you can see this is a balloon-based technology, which has a ultrasound transducer in the middle, and this sends off ultrasound waves to try and modulate that the sympathetic nerves. And these are the results. So compared to sham, once again, you see that there is a reduction in blood pressure. And so now we have quite a lot of data on all these studies now that actually, compared to a sham, these technologies do work. And in the last 1 or 2 years, we've had the results of the pivotal trial for spiral hypertension off. Same kind of study design. Patients who are hypertensive had all their medications stopped, and then they were randomized to either renal denervation or sham control. And at 3 months, they had their endpoints checked. And in this case, it was ambulatory blood pressure. And what did the results show? So very nicely, patients who were in the sham group, as expected, not much change in their blood pressure. But the ones who had active intervention, so they had renal denervation with a spiral catheter, had a significantly reduced blood pressure, both measured in terms of ambulatory as well as office. And what happens when you do your 24-hour blood pressure? So this is the patients at baseline, and after intervention, in the sham control, nothing changes, which is what we would expect. But you can see those who went for renal denervation, they had blood pressure reduction at all the time points in the day. So this is very attractive to us because, as you know, medications have their peaks and their troughs, and perhaps the blood pressure lowering effect of blood pressure of medications is not 24 hours. But you can see from this demonstration that perhaps with successful renal denervation, you get a 24 hours effect on blood pressure. Hence, you get a continual blood pressure lowering effect. You remove that peaks and troughs effect of taking medication and medication compliance. And you know, we've got more and more data now. So I just wanted to show this because it's an Asian presentation. This was presented 2 years ago. So this was from our colleagues in China, and they designed a very novel balloon. This is a balloon, and it has cryotechnology. So instead of burning things, it seems to be freezing the nerves. And once again, in a non-randomized sample, they showed reductions in blood pressure. So it's very, very exciting, targeting the renal sympathetic system. But there are other technologies on board as well. So this is baroreceptors. So baroreceptors, you know, are typically in the carotids as well as in the aorta, and they are mechanoreceptors. So they respond to stretch and wall tension. So the easy way to think about it is you've got high blood pressure, your wall is going to be stretched, and the negative feedback to this would be, of course, to lower your blood pressure. And so this was one of the first technologies. This was an implantable device, pretty much like a pacemaker, but with an electrode that was stimulating the baroreceptor center. And in a series of non-randomized studies, they showed actually that when the device was switched on, there was a significant reduction in blood pressure. Now, the initial devices had some issues in terms of procedural as well as post-procedural complications, but the technology has been refined, so the device actually is smaller now, etc. But I think the latest that we've heard is that the trials have kind of slowed down as well, and so we have to wait and see. So that's fairly invasive. You need to put something into the body. You need to have electrodes somewhere in your near your carotids. So this is a slightly less invasive technology, but it's really quite similar to the previous one. So what this does is that this is the Vascular Dynamics Mobius HD device, and what it is a passive endovascular baroreceptor amplifier. So what it does is basically something which looks a little bit like a stent. You put it very near the carotid body, and this will slowly, in a way, so-called self-expand, right? And so this gives a little bit of a stretch and hopefully activates all those feedback systems to try and modulate your blood pressure. And so this was presented and published about 2 or 3 years ago in patients who had the procedure done, as compared to those who, when they were assessed over time, they could see that there was a reduction of blood pressure as compared to baseline. So of course, this is a first-in-man study, very small patient size, only about 30 patients, but certainly very, very promising. What other technology is there? So this is ultrasound ablation, IVUS guided, of the carotid body. So the carotid body actually is a chemoreceptor and works pretty much like all the other receptors in the body. When it detects certain stimuli, it will activate the neurohormonal system to try and reduce, in this case, blood pressure. So what this technology does is that you introduce your probe into the jugular, and then using an IVUS, you assess where the carotid body should be. You can see very nicely here, when it's below the bifurcation, you see only one vessel. Then when it's above the bifurcation, you can see the 2 vessels. And that generally is where the carotid body is thought to lie. And then you can direct the transducer and perform some ultrasound ablation. And, sorry. Okay, so in this study, there was a first-in-man again. There was a reduction in blood pressure of between, I think, about 9 millimeters mercury at 6 months post-procedure. So this is really something that is in its infancy, but pretty exciting as nonetheless. And then the last technology I want to just discuss is the ROX AV coupler. I think some of you may be familiar with this. The theory is that we have noticed in the past that patients, for instance, in end-stage renal failure, once they have their fistula created, their blood pressure seems to drop. And so this technology is based on that kind of principle. Basically, there is a iatrogenic fistula created between the iliac artery and the vein, as you can see here on the angiographic appearance. And you can see that this actually leads to an immediate blood pressure lowering effect. Because you can tell that this is during the implant, this is when they occlude, and then when they open, and then when they occlude again. So you can see that this certainly looks quite promising. And this is the, once again, the first-in-man study showed very impressive blood pressure reductions in terms of office as well as ambulatory blood pressure. The one concern, though, is that there was a bit of increase in venous stenosis. This was treated usually with angioplasty techniques. And they believe that these things are sustainable up to about a year. Now, having said that, I think the last that we've heard is that the big trials in this have now been put on hold because of some safety concerns. So we're not entirely sure how this is going to pan out. So in summary, in the last 20 minutes, we've had a whirlwind tour of a range of different devices. I think I have to bring back that enthusiasm a little bit just to remind us once again of the ESC guidelines. So just to say once again that use of device-based therapies is not recommended for routine treatment of hypertension. And we need to wait for more safety and efficacy data, and we should hopefully get that from clinical studies and better performed and better executed randomized controlled trials. Having said that, I think cautious optimism is warranted at the present time. Thank you very much.
Thank you, Professor Tang, for your very informative talk. Now, Professor Sadik and Professor Tang's talks are open for discussion. Any questions or comments from the participants? Professor Sadik, may I ask you a question?
Sure, please.
Could you elaborate more on the use of calcium channel blocker in patients with coarctation of the aorta? Because you said that it's a contraindication, right? It's not good to use calcium channel blockers for patients with coarctation of the aorta. So why?
There are two subgroups where we normally tend not to give calcium channel blockers. One is where you have a severe left ventricular dysfunction, particularly in the presence of a coarctation which still has a residual gradient. And the second subgroup is the one where you have significant aortic root dilatation. And I think otherwise in refractory hypertension, which we see sometimes, or resistant hypertension, which we see sometimes in patients with coarctation of aorta, you can actually use calcium channel blockers, and we do use them. So it's not that they are absolutely contraindicated. It's only certain situations where you would not prefer using them, and you would prefer the other agents to be used.
May I ask a question?
Sure.
Yeah. So, in terms of coarctation, how for a practicing adult cardiologist like myself, how much should I search for it in patients? I mean, what are the in patients? I mean, should we send everyone for an MRA, for instance? What do you suggest?
I think that will be a bit too much if we send everybody for MRA. I think the whole concept is that we should be very carefully looking for it. And I think if you have any doubt in terms of your lower limb pulses, any discrepancy, I think one thing obviously is that you should always be looking for it. You see any adult patient, you should look for coarctation. And I think we all know about that. But I think more careful when I say is that I think a upper limb, lower limb blood pressure measurement, if you have a slightest doubt about the difference in terms of right arm, left arm, or upper limb, lower limb blood pressure difference, you should always be thinking about it. If any patient has significant aortic root dilatation, I think you should be thinking about it. If you cannot find another reason for coarctation, and if you see any evidence of aortic aortopathy in any arteries, you should think about possible coarctation. All of us know that we have found coarctations in descending aorta, we have found coarctations in abdominal aorta, we have found lately what we have interestingly seen, and I'm sure it's reported in the literature, is transverse arch, which you normally tend not to look for as a possible coarctation. And it's only the difference between the size of the transverse arch and the descending aorta, which actually tells you, and once you do the exercise testing or any further investigation, you find out that there is actually a transverse arch coarctation. So the answer is yes, we should be looking for them, but probably not to that extent that every patient should be subjected to MRI or CT.
Thank you. And Professor Tom, may I ask you a question?
Sure.
So how often do you use renal denervation therapy for your patients?
Yeah, I think that's a great question. So I have to say that we have slowed down a lot in Singapore, mainly because, like I mentioned, the guidelines do not support doing this in routine clinical practice at the moment. I think we are very encouraged by the recent publications. I think at the moment now, we still tend to target it for patients with resistant hypertension. Although currently now with the new publications, I think maybe we will be moving the patient population a little, expanding the patient population. We have collaborations with your colleagues in Taiwan, and I think Taiwanese practice and the threshold for renal denervation is much lower. So I think that's really the way we want to try and hit towards. Yeah.
Thank you for your comment. Because of time constraint, I have to close the webinar very soon. I would like to thank again all our speakers and participants. I would like to thank also the IT staff of the APSC Cloud for supporting this webinar. Thank you for participating in today's webinar. We hope to see you again next time. Now, I have to close the session. Have a wonderful day. Bye-bye.
Thank you very much. Thank you.
Bye-bye.